started with our next lecture by Dr. Quinn. Hey. Hello, everyone. For the interns who don't know me, I'm Antonia Quinn. I am one of the, definitely senior faculty here at this point. I also have a really cool job that I'm the associate director for clinical skills in the medical school. So I may come calling to ask you guys to help us out with physical exam labs, teaching the first and the second year students. And I know some of you guys are already doing that, and it's a really great experience. So, but I also have an interest in sports medicine as well as in orthopedics. So today I'm going to talk about foot and ankle trauma. So we've done the upper extremity, and I just happened to randomly pick the lower extremity today. So this is kind of cool. So today I want to talk a little bit about a review of the anatomy, because to really review x-rays, you need to go and have a sense of the anatomy. So I know it's probably been a little bit of time since you last reviewed the bones of the foot. So we'll talk about that a little bit. We're going to talk about grading of ankle sprains. I'm not going to talk about the Ottawa rules because you guys have looked them up and have probably talked about them ad nauseum. I'm going to talk mostly more about radiology. And so, but we'll talk about grading ankle sprains, because that will lead into a discussion about high ankle sprains and more higher level ankle injuries and some other, and a couple more cool cases. So this is going to be interactive, and let's take a look at some of the anatomy. So, oops. Now that I gave it away, what's number one? What bones are those?
Metatarsal.
Good. And number two? There's three of them, so it's probably the plural of those. I heard it. Somebody said it. I heard it over here. Uniform? Cuneiforms, okay. So these are your cuneiforms. There's three of them, so they're on the medial aspect of the foot. Good. So number three, what do you think that is? It looks like a boat, yes.
Navicular.
So this is your navicular. And what about number four?
Phalange. Yeah.
So those are your phalanges. And number five? Cuboid. Cuboid. Right. So that's on the lateral aspect. And then number six? And finally, so that's going to be your calcaneus, right? So again, just remember there's three cuneiforms. They're on the medial aspect. Your navicular looks like a boat, and the cuboid looks like a cube. Just a quick review of the ligaments. These are also important to remember. Number two is your posterior tibiofibular ligament. And number three is your anterior talofibular. This is the most common in the injured ligament when it comes to ankle sprains. So it's a classic board question you guys will have to answer. And number four is your calcaneofibular ligament. These are really important when it comes to high-grade ankle sprains, syndesmotic injuries, the really, really severe ankle sprains. The calcaneofibular is also one. And then finally, your anterior tibular ligament as well. So this is a picture of a normal foot X-ray. Again, just to identify. Here you've got the navicular here. Here's your cuboid. Here are your cuneiforms. Is this normal, or what is this called up here? Right, so these are your sesamoid bones, and it just happens that this person has a bipartite sesamoid, which can happen. If they're tender there, then it may look like a fracture, but that's very rare. For the most part, this is probably just a normal variant. So just a little bit of epidemiology on ankle sprains. There's about 23,000 ankle injuries per day in the United States. So this is something you will definitely see many times in your lifetime. As many as 1 in every 10,000 visits is some type of ankle injury. And this includes both sprains and fractures. In adults, ankle sprains are more common than fractures, but foot fractures do make up 10% of all all fractures overall. Fractures are more common in children rather than ankle sprains because the children are a little bit more, they have more stretch in their ligaments. And so they actually fracture their foot more than getting actual ankle sprains. So you have a basketball player and you diagnose him with an ankle sprain after an inversion injury. So how do we grade ankle sprains? So it's a three-part grading system. So first is grade 1, which is basically no ligamentous disruption. This is just stretching of the ATFL and the CFL. These are the patients that come in, they're walking, but they follow the Ottawa ankle rules. They might be a little bit swollen, but they're able to ambulate. They don't have any tenderness anywhere. You do ligamentous testing, they're fine. Probably you don't even need to get an x-ray, even though I know most of us will probably do it because they've been shown that a lot of people don't follow the Ottawa ankle rules. But these patients, rest, ice, compression, elevation, Jones dressing is definitely helpful, and you can send them home. Grade 2, this is an isolated tear of your ATFL. The patients may have a positive anterior draw on physical exam, and we'll talk about that in just a second, what that means. And then, so these patients, you probably get an x-ray because they may not be able to walk as well. They'll be extensively swollen, they'll have tenderness, and they'll have laxity on ligamentous testing if you're able to perform it. And then finally, grade 3, these are your patients who look really uncomfortable. They're not able to walk, there's extensive ecchymosis, extensive swelling, and they've torn both their ATFL and their CFL. So these patients are the ones that we're really concerned about, especially for syndesmotic injuries, and we'll talk about what that means in just a second. So just a little bit again, using anatomical drawings, what I mean. So grade 1, you just sort of stretch the anterior talotibial ligament and the CFL. Patient looks good, send them home with Bryce therapy. The grade 2, they've partially torn their ATFL. They're a little bit more uncomfortable. And then grade 3, these are severe injuries. They've bagged their ATFL as well as their CFL rupture. And they may even have a partial tear of the posterior tibial ligament. And once you've torn all these, you're also at risk for a syndesmotic injury. So what do I mean by anterior draw? This is just like the anterior draw in the knee. You stabilize the tibia and the fibula, hold onto the calcaneus and anterior pull on the leg. Usually, you want to have the leg in about 20 degrees of plantar flexion when you do it. A little bit of give is fine, but it's really what you want to get is that firm end point. If it feels really mushy and lax, then you probably have a tear. The talar tilt tests for the integrity of the calcaneofibular ligament. And so this is usually, you hold the foot and provide an inversion force. Usually about 5 degrees is normal on a normal foot. Anything greater than that could mean that you might have a tear of your CFL, and looks for as well as the ATFL. So these tests are really, really difficult to do if someone has a severe grade 3 sprain because they're so swollen, they're ecchymotic, they're tender. So you may want to delay doing these exams. Treat them, if they can't do this, treat it as a grade 3 sprain, meaning immobilize actually for 10 days, and then have them follow up though with an orthopedist or sports medicine doctor in about 3 days. Because if you delay the specific ligament testing for 3 to 5 days, it improves the sensitivity to 96% and the specificity to 84% for diagnosing ligamentous injury. So if you're unable to do these, a talar tilt or an anterior draw because of patient discomfort, that's okay. You'll probably get a higher yield if you have to give them close follow-up. So you're reading the paper, it's a Sunday evening, and you hear that a football player had to leave the game because he everts his ankle while he's being tackled, and he's been diagnosed with a high ankle sprain. So what does that mean? What is considered a high ankle sprain? How is it diagnosed, and what is the treatment? So what a high ankle sprain is when you are running usually on a dorsiflexed and everted foot, and you get a lateral force to the knee. And what that does is that it forces your tibia to rotate on the dorsiflexed and planted foot. And it basically tears your posterior tibiofibular ligament, your anterior talofibular ligament, and the posterior, and it gets your syndesmosis. So this is a really, really serious injury. And the way you can diagnose it on physical exam are two major tests, which is the squeeze test and the cross-leg test. Cross-leg test is you put the affected leg over the opposite knee and apply a medial force. And while the squeeze test is basically you're squeezing the calf, squeezing the tibia and the fibula together. And if pain is a positive sign as a possible syndesmotic injury. This I recommend doing the calcaneal squeeze test on anyone who comes in with an ankle injury, because this way you don't want to miss a syndesmotic injury. It's really quick and easy to do. And you should be examining the fibular head anyhow, right, for anyone who twists their ankle, because you don't want to miss a Mason-Epps fracture. But unfortunately, these are not very, very sensitive nor specific tests. If you just use physical exam, you're going to miss about 20% of syndesmotic injuries. So we do have to go for the X-ray. And how do we diagnose a possible syndesmotic injury? We look at these radiographic measurements. One is the fibular tibial overlap. The other one is the tibiofibular clear space, and then you've got the medial clear space. These 2 points A and B are measured about 1 centimeter over the tibial plafond. And normal measurements is that you want to have greater than 6 millimeters of overlap. And so if it's less than that, meaning that the fibula is displaced more laterally, or if you have greater than 10 millimeters of space at the medial clear space, then be highly, highly suspicious for a syndesmotic injury. And so what do? These patients need to be immobilized. They need to have close orthopedic follow-up, mobilization for about 10 days, then range of motion exercises. And if you're a professional athlete, then after that, you do have more heavy drills, and they may require surgery in the end. But what's really important is to tell your patients that these take a long time to recover. Normal ankle sprains, usually you're probably better in 1.4 days. These take almost 45 days to recover, so it's a really serious injury. So make sure you do the squeeze test, and if you're at all suspicious based on mechanism, you'll get that X-ray. So a 23-year-old snowboarder presents with pain to his lateral ankle, and you get this X-ray back. So what does the radiologic arrow sign show? Do you know what the diagnosis is? This, for once, does not have an eponym. It's called a snowboarder's fracture, because it's really, really common in snowboarders. And what it is, it's a lateral process of the fracture of the talus. Usually, you could just be very suspicious of this in a snowboarder who says, "I sprained my ankle," especially if they were dorsiflexed and everted. But keep in mind, even though we probably don't see a lot of snowboarding accidents here in East Flatbush, it's very common also with skateboarders. So that's probably the way you see it, or motor vehicle accidents, especially if your foot is planted on the brake. And they come in with pain over the talus. They may have what's called a V sign on X-ray, and have a small subtalar effusion as well. And the reason we care about this is because they have a high risk of malunion. So if you're suspicious for a talar fracture, you want to make sure that you refer to ortho because they might need operative repair. But again, it's about 34% higher incidence in snowboarders, but think about it as well in people who are skateboarding. And then finally, you have a 35-year-old female who jumps from a balcony. What injury is she at risk for, and how is the diagnosis made? So what's the most common bone fractured from jump from a height in the foot? Calcaneus. Good. So do you guys see the fracture here? So this is the fracture here on the lateral, and then on the AP it's right here. But unfortunately, they're not always that obvious, right? So do we have another way to diagnose a calcaneal fracture besides actually seeing the fracture? Somebody's angle. Again, if it's orthopedics, it often has an eponym. So we call this Bowler's angle. So if you're suspicious based on mechanism for a possible calcaneal fracture, you want to measure what's called Bowler's angle. And so what you do is you draw a line from the upper edge of the calcaneal body to the upper edge of the posterior facet here at the subtalar joint. And then you draw another line from that same upper edge of the posterior facet to the anterior process of the calcaneus. And when you do that, you get this nice little angle. And usually, between 28 degrees and 42 degrees is normal. So why is this important? Because having a Bowler's angle less than 21% is nearly 100% sensitive or 100% specific, with a likely ratio of 110 of having a calcaneal fracture. So it's really, really, really important to measure these angles, especially if you don't see the fracture. And then finally, also don't forget calcaneal fractures, especially for a jump from a height. 6.4% also have associated lumbar spine fractures. So you want to go and get that, what we call here the jumper series, which includes lumbar as well as thoracic and C-spine x-rays, because you don't want to miss this fracture, because again, it'll be axial loading. So have fun. Continue exercising even in a pandemic. My kids and I were supposed to run a 5K together, which got canceled, so we made our own and printed out bibs, and just don't get hurt.